Welcome and thanks for joining us on the Flourishing Life podcast, where we will be discussing what we see on the daily. We're Jackie and Tad from Flourish Medical Wellness in Savage, Minnesota, where listening to our patients is the priority. Our foundational medicine clinic bridges the gap between traditional and functional medicine. We are pattern recognition specialists that focus on individualized patient care and health optimization. With a combined 30 years of medical experience, our goal is to provide insights that will help you take control of your health. Be sure to follow us on Instagram at Flourish Medical Wellness and on our website, flourishmedicalwellness.com, to stay up to date with what's happening at the clinic. The following content is the opinion of Jackie and Tad Tewes and is not intended to diagnose or treat any medical conditions. Please be sure to speak to your healthcare provider for your unique needs. Hey y'all, Tad and Jackie here from Flourish Medical Wellness, where our priority is listening to you, our patients, and practicing a team approach to foundational wellness for long-term healing. Today we are back continuing our series on medical misconceptions and myths and things that patients bring into us that they hear that aren't exactly the whole truth, the full truth, or sometimes just not true at all. Today we are talking about thyroid, which is actually a personal topic for me. This is something that I personally deal with, and so I'll share a little bit of my story as we go throughout the talk today. But it's important to understand what the thyroid gland is. The thyroid gland is the master control center for the metabolic function of every single cell in our body. Thyroid hormones control the efficiency and speed of which all of our cells work. Thyroid disease, when you have inadequate production of thyroid hormones, accelerates the aging process. So our first myth that we're going to dive into is that your thyroid labs are normal, so it's not your thyroid. And so here I want to just explain to you guys all of the different thyroid labs that should be being tested. So when I was at my previous job, I actually worked with several different providers. I would come to work in the morning, would literally take naps in my car because I was exhausted to the point where I was like, I need to get in a nap before I can even go in and tackle my day. I was also the only one in the office who always had a heater on, whether it was winter, whether it was summer. I was freezing cold, and I had a lot of difficulty moving my bowels every day. And so every single provider that I worked with in that primary care family practice clinic checked my thyroid hormone. They thought, she has all these symptoms, she must be hypothyroid. But every single time they checked it, I was normal. And so what they were checking for me was only what's called TSH, or thyroid stimulating hormone. So if you are somebody who thinks you may have a thyroid issue or you have low thyroid symptoms, I'm going to explain to you all of the different pieces of a thyroid panel and what they mean, and hopefully you can use this information to advocate for yourself and ask for more testing, because if they're just checking a TSH and telling you that's normal, that's not the full thyroid story, that's not the full thyroid picture. You may be having issues in some of these other areas that they're not even checking. So the very first thing to understand is that there are at least 6 very important levels to check. That's going to be a TSH, the thyroid stimulating hormone, your free T3, your free T4, your total T3, total T4, and then your reverse T3, as well as TPOs, or thyroid peroxidase antibodies, and your thyroglobulin antibodies. So if we're really getting a comprehensive look at a thyroid panel, those are the things that need to be included to fully understand what's happening with the thyroid function. So let's break that down a little bit. There's something called the HPT axis. So the HPT axis stands for hypothalamus pituitary thyroid axis. And this is a very complex system. There are multiple pieces involved that create and make sure that the thyroid is functioning correctly. So it starts in the hypothalamus. The hypothalamus releases what's called thyroid releasing hormone, which signals the anterior pituitary to make TSH, or thyroid stimulating hormone. This thyroid stimulating hormone is what signals the thyroid gland to then make your actual thyroid hormones, T4 and T3. So again, TSH, thyroid stimulating hormone, the most common thyroid lab test that is checked, is not even a thyroid hormone. It's the signaling hormone from the pituitary. Your actual thyroid hormones are going to be T4 and T3. So T4, this is a very highly stable molecule. The half-life of this is about 7 days, and it is a prohormone, meaning its job is to turn into something else. It is a prohormone specifically for T3. T4 is waiting to become T3. So always remember, T4 is the inactive form of thyroid hormone. T3, what it turns into, is the active form of thyroid hormone. So what that means, T4 means that there are 4 iodine molecules attached. T3 means that there are 3 iodine molecules attached, and we'll touch on the importance of that and what that looks like. T3, again, that is your most metabolically active thyroid hormone. So when we say metabolically active, that means it is what is acting on the cellular level to create the thyroid response to do all of the work that it's supposed to do, especially in those peripheral tissues. 80% of that conversion from T4 turning into T3 actually happens in the periphery. And remember, T3 is 10 times more physiologically active than T4. Then we have RT3, or reverse T3. So think of reverse T3 as the emergency brake on the whole system. We don't like RT3, we don't like reverse T3. What happens is some of that T4 can actually convert into reverse T3, which is not active T3. It is a stopper. So if we have too much RT3 conversion, we are not getting enough of the active T3 hormone. The things that drive reverse T3 and the increased conversion to reverse T3 is going to be things like stress. That's probably the number one thing that we see. Gut dysbiosis can also impact that conversion and create more of the reverse T3, high toxin load, and different types of nutrient deficiencies like selenium, for example. Total T4 and total T3 are the total amount of T4 and T3 hormones circulating in the blood. This includes the free amount and the amount that is bound to that carrier protein, or the thyroid binding globulin. We don't really look at total T3 and T4 a whole lot here because it's not the active form, it's not the available form for the cells to use, and so we don't often need to dive into that one as much. But that free T4 and free T3 are the thyroid hormones that are unbound to that thyroid binding globulin, and it has to be unbound for the cell to be able to use that. This is the metabolically active form of thyroid hormone, the free T3. If we're only checking TSH, total T3, total T4, and those look fine, that doesn't mean that our free T3 and our free T4 are normal. And so we have to make sure we are seeing the full picture. So what happens is we have these enzymes called deiodinases. Deiodinase 1, 2, and 3. Deiodinase 1 is responsible for that cleaving off of the iodine molecule, so cutting off one of the iodines from T4, turning it into T3. D1 is present in our peripheral tissues. D2, deiodinase 2, is present in the pituitary. And then we have D3, which is what's going to turn the T4 into reverse T3, which again, we do not want that. So the activity of these deiodinases is what determines the tissue and cellular thyroid levels, not a serum TSH. So just basing our labs on that serum TSH does not give us the full picture. Again, the most common things that are going to impact these deiodinases are going to be stress, obesity, chronic dieting, diabetes, insulin resistance, and inflammation. All of those things are going to decrease D1, or the peripheral conversion, so at our hair, skin, nails, heart, our peripheral tissues. It's going to increase the D3 conversion, meaning more reverse T3, and it's also going to increase D2, which is important because if it's increasing that D2 activity in the pituitary, it's making your labs, your TSH, look normal, but we're not actually getting enough of that T3 conversion in the cellular peripheral tissue. So remember, pituitary T3 levels are determined by that D2, which is 1,000 times more efficient with T4 to T3 conversion than the D1, which is in the peripheral tissues. So in the pituitary, 80 to 90% of that T4 is converted into T3, but only 30 to 50% of that T4 is converted to T3 in the peripheral tissues because of those ways that D1 is impacted. The inflammation, the obesity, the diabetes, those things are so prevalent in America. And so when you're overweight, you have inflammation, you have insulin resistance, you have high stress, your body will not be able to do enough of the conversion from T4 to T3 in the peripheral tissue. Now, this is also going to play a role when we talk about how we treat thyroid and how we manage that, because we can give the body a whole bunch of T4, but again, if that deiodinase 1 is not working well, we're not getting enough conversion into the T3 in the peripheral tissues, it doesn't matter how much T4 you give, you're not going to have symptom resolution, and you're not going to make more of that T3 on its own. So remember, you can have adequate levels of T3 in the pituitary, but low levels in the peripheral tissues. And then those last labs that we look at, the TPO antibodies and the thyroglobulin antibodies, these are specifically looking at if your immune system is making antibodies against your thyroid. So it's telling your immune system to attack the thyroid gland. That's called an autoimmune thyroiditis, or Hashimoto's is the common term for that. Now, the other important thing to remember with Hashimoto's is that TSH can actually be normal even when Hashimoto's is present. And this is specifically what was happening with me. My thyroid antibodies weren't even checked, and so that was missed for many, many years, the fact that my body was making antibodies to my thyroid and that I had Hashimoto's. So just because the TSH is normal doesn't mean that there's nothing else going on with that thyroid. We need to get a full panel of thyroid hormones to best understand what's happening in relation to your peripheral tissues, your immune system, and how that thyroid is working.
Why we do things like only testing a TSH in this country. This is where insurance has a hand in driving care. So when we're looking at a person's thyroid status, in the ideal world, we're getting a TSH, a free T3, a free T4, and thyroid antibodies on everyone, because all that provides valuable information. But what insurance drives is cost-effective lab testing, saying, well, if we just get a TSH, then we're getting a snippet of that feedback loop, and as long as the rest of the whole feedback loop and that person systemically is functioning well, then we can assume based off of that TSH value. Again, this is an assumption, and there are economic reasons or cost reasons from an insurance company that are driving care in that direction. So let's talk about labs. So the second myth, your labs are normal. You don't have thyroid issues, even if a person has symptoms. And this is something that we talk about every day in the clinic is overall thyroid health. Starting with reference intervals. So when you get your labs drawn, that reference interval or reference range that's typically on the right side of the page, that is a population comparison. That is comparing you to other adult men or women, specifically drawn by that lab. So each lab makes their own reference interval, and it's basically a 95% confidence interval of where adults will fall. So it's a comparison of you to the population. It's important to note that that is not a health comparison. That is not saying this is where you should be optimally, and so it's important not to base optimal care off a population range, especially when America, as we know, is not the most healthy country in the world. So when we look at optimal ranges for things like TSH or thyroid stimulating hormone, an optimal range is going to be somewhere around 0.5 up to 2, where the reference range will typically fall for a lab is going to be about 0.45 all the way up to 4.5, essentially a tenfold increase for just that TSH. And that much wider range, again, looks at the full population, but not what ideal is. For free T3, or that rocket fuel in the thyroid world, if we can have that be around 3.2 up to 4, then we know that the body is getting adequate metabolically active thyroid hormone circulating, and that's what we want to see, because that lets us know that that conversion from T4 to T3 is occurring. We're seeing that in the bloodstream, and it's not bound to a binding protein for thyroid. And then for T4, or that longer lasting hormone that's not very metabolically active, we want to see T4 around 1 to 1.5 ideally. Now, reference range, again, will be wider than that, especially on the low end. It goes down to about 0.8. But what we know is we need some of that T4 circulating. We need that because that's the fuel for conversion to T3, mainly in the liver and the other peripheral areas of the body. And then for reverse T3, we want that to really be under 12. And that's an important piece to know because we want to make sure that that T4 is getting converted to T3 so we can see that metabolic action from thyroid hormone.
Let me just insert here. So the other thing you have to remember is it's not just comparing you to the whole population, it's comparing you to the population that's been checked for that lab test specifically. And so when you come into a clinic and you present, there's a reason that your provider decides to order the test that they order. And that's going to look like me. Like I came in, I said, hey, I'm tired all the time. I am constipated. I'm freezing cold. And they thought, oh, you probably have low thyroid. These are low thyroid symptoms. So they checked my thyroid. And that's where that range comes from. It comes from the people that we've checked for that test. So the majority of people that we're checking are having thyroid symptoms. That's why we're checking it. So we're literally using that reference range, comparing you to everyone else that has those same symptoms, but then telling you you're normal.
Absolutely. And the other piece too is by just checking a TSH. So remember, TSH is that piece of the feedback loop that's coming from the anterior pituitary gland, that specific part of the brain. And if we're only checking that, we're getting a snippet on what the pituitary gland is seeing. Okay? Even if those levels of thyroid hormone are normal in the pituitary gland and in that area, it does not necessarily relay that there are normal levels in the periphery of the body. And we have thyroid receptors in almost every system in our entire body, from our heart, gut health, pulmonary function, other endocrine areas as well. There's thyroid receptors everywhere, and so we need to have a handle on that with also testing the free T3 and the free T4 to optimal levels. When we look at types of hypothyroidism, so hypothyroidism is underactive thyroid, specifically underactive thyroid function that can lead to symptoms and issues with quality of life. So primary hypothyroidism is where we are seeing lower circulating thyroid hormones, specifically T4 and or T3, and what happens is the TSH or thyroid stimulating hormone from the brain will respond by going up. And that's where, if we're just testing a TSH, a more traditional setting, then it would be a TSH that's going to be up on the higher end of that reference interval, usually around 4 or higher. And that is telling us the brain is needing to send a bigger signal from the pituitary to the thyroid, and the brain's basically shouting at it saying, hey, guys, I need more of this. We need more thyroid circulating in the bloodstream for all of those areas of the body. Secondary hypothyroidism is typically going to be more related to outside of the thyroid with loss of the efficiency of conversion of that T4 to T3. So T4, remember, it's long acting, it's not very metabolically active. And if that less metabolically active form is not getting converted to T3 in the periphery of the body and the liver, then we can see hypo or underactive thyroid symptoms, especially with things like energy, brain fog, constipation. And that is something, if you ever come across the term low T3 syndrome, that is another term referring to having enough of that less metabolically active hormone T4, but not enough of the metabolically active T3. And then tertiary hypothyroidism. This is looking more at people who have adequate thyroid hormone levels circulating, but the receptors are not responding to that. So labs look good, but the person still is demonstrating hypothyroidism symptoms, and that receptor insensitivity or desensitization can be due to things like toxin exposure, heavy metals, phthalates can play a role in that, and there's a lot of different pieces that can affect how a cell actually uses those circulating thyroid hormones. All right, let's talk about thyroid symptoms. So if you do a quick Google search for thyroid symptoms, it is going to be an exhaustive list. There are over 200 potential symptoms of hypo or underactive thyroid hormone. Jackie, what are the top 3 that you hear in clinic?
Probably fatigue, weight gain, and brittle hair, nails, or feeling cold.
Yeah. And there are tons, but the big ones are fatigue and energy, or I just don't have the energy to do what I used to be able to do. Brain fog is a big one as well. When we think about access to short-term memory, having trouble with word finding, or that word is always on the tip of my tongue, but when I'm meeting with a client, I can't get that word out. When we look at hair, skin, and nail changes, constipation, those are the very common symptoms of hypothyroidism that we see in the clinic. Other symptoms that can happen too are effects to mood, or people becoming more apathetic over time, where there's less highs, less lows, just kind of dulled out in terms of their mood. We can see that with hypothyroidism. The weight gain as well. So when I'm in the clinic looking at a free T3 on someone's thyroid panel, if that is below 3, weight loss and improvement in body composition gets very, very difficult, because that metabolism, it's trying to drive forward, but it's essentially doing it with the parking brake on, because there's not enough of that metabolically active form of thyroid hormone to drive metabolism. Maybe we're getting enough of the T4, but that T3 that really drives metabolism and just burning calories by waking up every day, if that's low, weight loss gets very, very difficult. Thyroid can also lead to infertility. When we see low thyroid levels, especially in younger ladies who should not have fertility issues, there's no structural issue, there's no sex hormone issue, but we see significant hypothyroidism, that can play a huge role in infertility. And then on the flip side, once we get that thyroid corrected, oftentimes fertility implantation occur. That's really fun, by the way. That's one of our favorite things as providers, is for a younger lady who's been trying to get pregnant, has some underlying thyroid issues, we get that worked out, and then she gets pregnant in the next 2 to 3 months. It's very gratifying. Constipation, because of all the receptors in the GI tract for thyroid hormones, we also can see things like arrhythmias, or changes in how the heart functions and beats because of all the thyroid receptors in heart tissue as well. And then also swelling. So when thyroid hormone gets low enough, we can see people appear puffy or hold on to fluid. And a big part of that is a substance called mucin, and how it plays into this whole picture. Some of the classic pictures that we look at in textbooks of people who are really hypothyroid will have a very puffy, rounded face. And that is something, if thyroid hormones are low enough, we can see that. And it's very easy to pick out when somebody walks into a room and has those types of facial features. Next myth, levothyroxine or Synthroid is the best treatment for hypothyroidism. Levothyroxine is the synthetic form of T4, that less active form of thyroid hormone, and it is the most widely prescribed thyroid medication on the planet. The reason for that is it is easy to prescribe, it is low risk, but the problem is it assumes that that person's body is going to be able to efficiently convert that T4 to T3, that really metabolically active form. So levothyroxine has been around for over 100 years. And this medication was designed even before the FDA required testing on efficacy of medication for symptom relief. That's super important, because levothyroxine basically was grandfathered in as a medication that would and could be used for hypothyroidism, even without the necessary checks and balances to say, hey, is this going to help people in terms of symptom improvement and quality of life? Now, with levothyroxine, there's a lot of people who will see mild laboratory improvements when we check their blood, but they'll still have the symptoms, and they'll still have the poor quality of life and be symptomatically hypothyroid. That's where we look into other options for treating hypothyroidism, especially if we're going the pharmaceutical route, other medications. Other things to know about levothyroxine, which is a generic medication, is there do tend to be more fillers, more dyes in there as well, and generic medications are going to have a higher variance rate, meaning that, let's say 100 micrograms of levothyroxine, it may be 91 micrograms, it may be 114 micrograms. There's much more variance that is acceptable in that single pill. Now, there is a trade name or a brand name of T4 called Tyrosint. It is a much cleaner medication. There's not the dyes, not the fillers that there are present in levothyroxine, but that does come at a price increase too. So if someone is looking for a cleaner version of T4, Tyrosint is definitely a better option. It is just more expensive. And then other options for medications when we're looking at how to address not only labs but also symptoms are going to be desiccated thyroid. So desiccated thyroid comes from pigs and it contains both T4 and T3 in it in specified amounts because again, we're looking for hormonal mimicry. We're trying to give a person what their body should normally have, and what we're going to see is a fair amount more T4 than T3 because T3 is so metabolically active. You can also do compounded T4 and T3. This is something that we like to do because we can specify to the pharmacy exactly how much T4 and T3 to put in each capsule, and it's a way to individualize care and individualize those specified amounts for that person. And you can also look at how they react and adjust those amounts in the future too. And then looking at T3 specifically, you can prescribe T3. It's called liothyronine. Cytomel is going to be the trade name of that.
All right, myth number 4, T3 is bad for the heart. So we do use a lot of T3 here in patients that we're treating for hypothyroidism or low T3 syndrome if they prefer to go the medication route. And we're not afraid of it. We use it appropriately, the low and slows, but we do hear pushback from patients that their provider thinks it's not necessary or maybe it's not good for them to be on T3. And a lot of that will stem around kind of this misconception and an idea that T3 is bad for the heart. Okay, so remember those deiodinases that we talked about, and that is that enzyme that cleaves off an iodine molecule and turning T4 into T3. So remember, deiodinase 1 is going to be where we're seeing T4 to T3 conversion happening in the periphery. The D2 is going to be that conversion of T4 to T3 in the pituitary only. And then D3 is that conversion of T4 to reverse T3, which we do not want. So it's important to understand that there is no deiodinase in the heart, which means we must have enough peripheral T3 to give adequate levels to the heart. And also remember that those things like stress, insulin resistance, diabetes, obesity, inflammation, toxin load decreases the deiodinase activity in the periphery, but increases it in the pituitary. I would say 90% of Americans are dealing with one of those things: stress, dieting, insulin resistance, diabetes, obesity, inflammation, or high toxin load. So what that means is that we're going to have less peripheral conversion in the tissue, more conversion in the pituitary, showing that the labs look normal, but we're not going to have enough T3 for the heart, for the cardiac function. So we actually see there are some emergency rooms who will use IV T3 to treat heart attack or myocardial infarction patients. Specifically, what we see is when a patient comes in with a heart attack and they have low T3, that has a higher risk of mortality, and they tend to have more severe myocardial injury. So T3 administration with an acute heart attack or an acute MI can actually limit the extent of myocardial damage due to ischemia, improve cardiac function after a heart attack, and it can also minimize scar formation and improve remodeling. So this is really important because, as we all know, heart disease, heart attack, it's a big problem here in the United States. And so now if we have all these lifestyle factors or these very common things that are lowering our T4 to T3 conversion in the periphery, we don't have enough T3 that we're getting to the heart. Your heart needs some T3. And so sometimes that needs to be given exogenously because it's not able to do that on its own inside of the heart. We also see that the literature shows that proper amounts of thyroid halts atherosclerosis, lowers cholesterol and triglycerides, which is also really important. There was a really interesting study, the Framingham study. The National Heart Institute started this study to figure out what are the big risk factors that tend to be present in patients with heart attacks. They wanted to identify what those big risk factors were. They studied thousands of men, and they found that there were some common risk factors in those men who had heart attacks, and they were high blood pressure, high cholesterol, increasing age, and then a family history of a previous heart attack. So Dr. Broda Barnes actually took this Framingham study, the findings from this, and implemented this. His hypothesis was that giving exogenous T3 would actually reduce the heart attack rates because he understood the way T3 worked in the heart and that the heart needed it to be able to function appropriately. So he looked at 1,500 of his patients, and based on the Framingham data, those risk factors, so the patients that had those risk factors, 72 of those patients should have had a heart attack, but only 4 of them actually had a heart attack. So this was a 90% prevention of heart attack in patients that should have had a heart attack based on the Framingham study results. The only thing that Dr. Barnes did was gave his patients T3 and T4. He didn't control for high cholesterol. He didn't put them on cholesterol medication. He didn't control for smoking. He didn't change their diet. He only made sure they were on T3. And the heart attack rate went down by 90%, which is pretty incredible. So the takeaway here is that T3 is necessary. It's necessary for our whole body. It's extremely necessary for our heart. And it's not something that you should be afraid of. If your levels are low, you're being monitored, and it's being treated appropriately. It's actually very cardioprotective and helps, like I said, with that remodeling and those effects that can happen after a heart attack.
All right, next myth. Medication is the only way to treat hypothyroidism. Now, medication is one of the mainstays in the United States for treating hypothyroidism, but the big goal here is if we can get people's bodies functioning well, if we can correct nutrient deficiencies, if we can get toxins out of the body, the hope is then that person's body is able to function in a way where that whole axis is working very well. The conversion of T4 to T3 is working very well also. And so the biggest takeaway is medication is not the only answer, and I would argue it's not the preferred answer. First thing that can help with treating thyroid is going to be iron. Specifically, we look at iron and ferritin. Ferritin is a person's iron stores. When a person is low iron, it can decrease that conversion of T4 to T3, but it can also increase the conversion of that T4 to reverse T3, which is not providing the metabolic benefits of T3 itself. We want to make sure that ferritin is over 70. For guys, I'd prefer to see it up over 100 for good iron stores. And iron is needed for transport of T3 within the cell, specifically into the cell nucleus, or that main working center of the cell where we have receptors for thyroid hormone. So when I think about people with low iron, and there's 2 groups of people that stand out in clinic, and one is going to be people who are vegans or vegetarians who aren't getting those good traditional iron sources like red meat, like other protein sources. But the second is women who have heavier cycles. So that never-ending battle with heavier cycles is there's a 3 to 7 day significant loss of iron, and then the body is trying to recoup that over 3 to 4 weeks, and then it happens again. So it's this never-ending battle for iron, and that can have significant effects on thyroid. And so even things like getting those cycles to be more regular, a little bit farther apart, lighter, that can have an effect positively on the thyroid. The second are going to be nutrients like iodine, selenium, and zinc. All of these are going to play a role in overall thyroid hormone function and synthesis within the body. And so checking out those nutrient levels is a big deal when we're looking at the whole thyroid picture. And then also understanding where that conversion is mainly occurring of T4 to T3. A lot of it is happening outside of the thyroid, specifically when we look at the liver. That's an area we can target to say, is this person's liver functioning well? Or in people who are taking in too much alcohol, is that liver having to work overtime to the point where liver enzymes are getting bumped up, and we're going to see that conversion within the liver for our thyroid go down because that liver is constantly dealing with toxins. The person's liver is the main metabolizer within the body. It's breaking down medications, supplements, alcohol. Basically anything that goes at that liver, it has the responsibility of breaking down. And if it's too busy breaking substances down to be converting T4 to T3, that becomes a problem. And we can see hypothyroidism symptoms worsen. So when we look at other ways that we can treat thyroid, just detoxing a person's body can be extremely effective, especially when we're looking at why a person who has pretty normal or pretty optimal thyroid hormone levels circulating, why aren't they responding? Well, if there are issues at the receptors for those hormones, specifically T3, that are not functioning properly or not functioning efficiently, many times that can be due to things like heavy metals, arsenic, mercury, fluoride can actually play a role, excessive exposure to fluoride, and then phthalates. Phthalates are going to be more so in cosmetics, hair care products, hairspray, and those can also play a role in decreasing the efficacy of those thyroid hormones, specifically at the receptor around the cell. Jackie, will you talk a little bit about circadian rhythm and how some of the other hormones within the body play a role in how well thyroid hormones work?
Yeah, so when we look at hormones, we have many different types of hormones in the body, things like cortisol, insulin, leptin, ghrelin, testosterone, estrogen, insulin. There's many of them. There's something called our hormone hierarchy. And so these specifically are going to be our hormones, which include insulin, melatonin, cortisol, and then leptin. And the body will prioritize these hormones. Think of it like this. If you're running from a bear, okay, your body goes into what's called fight or flight. So cortisol is high, and it does that to keep you alive. It does that to protect you. When it's in that cortisol state, it's not doing the rest of the stuff. Your body can't get pregnant. It's not focusing on sex hormones. It's not making adequate thyroid hormone. And so if we're constantly in this high cortisol fight or flight state, our body cannot make appropriate thyroid hormones. Now, it's really important to understand that high cortisol doesn't just mean I'm being chased by a bear. High cortisol can happen from work stress, life stress, family stress. It can also be induced by blue light. And we see this all the time where, people are on their phones before bed. When you're on your phone and you're getting blue light exposure right before bed, it's signaling cortisol. When cortisol is high, that means melatonin is going to be low. That means your body's going to be in that fight or flight. It can't heal. It can't do the rest of the hormone game that's supposed to be happening because cortisol is high. So it's really important that if we want to support our thyroid naturally, we have to remember those circadian hormones, the hormones that are triggered by light, signaled by light, where cortisol, insulin are going to be higher in the morning. Past noon, they're going to start to drop off, which is when we're going to start to see melatonin in the evening, the leptin overnight. We have to support it appropriately, or your body's not going to be able to create and make the thyroid hormone adequately like it is supposed to. The other important thing to understand is that leptin resistance and insulin resistance actually increases D3, that deiodinase 3, where we're creating more reverse T3. It lowers that deiodinase 1, so that D1, where we're getting less conversion in the tissue, which is where we need it, but we're getting increased D2, which is increased conversion in the pituitary. So labs look fine again, but symptomatically we're going to see thyroid symptoms because our peripheral tissues aren't getting enough of that T3.
And one other thing we should talk about is iodine specifically, because there is a ton of information, and I've even seen things circulating on social media about iodine and its role in thyroid hormone performance, treatment of hypothyroidism. So iodine has receptors all over the body. All of our cells have iodine receptors, and there are other substances that we're commonly exposed to, things like bromide, fluoride, chloride, basically anything in that halide family are going to have a very similar structure to iodine. And so when a person takes iodine, we need to be careful about how that's done, because iodine absolutely can help with thyroid function, but it needs to be done the right way, because if it's given in too high amounts, people can have significant detox reactions where they get headaches, they feel really sick, we see nausea, cramping, those types of symptoms. And so low and slow is an important way to be able to introduce or support iodine function, but it really needs to be done in a slow, gradual way. We can also use things like Himalayan salt to help if there are some of those detox type reactions. Those can help buffer those down as well.
Yeah, so think of it like this. We are literally drinking chlorinated water with fluoride, toothpaste with fluoride. So we're getting these chemicals every single day, which is then attaching to those iodine receptors. So when you start taking iodine, which we don't get a lot of, naturally anymore in our foods, it's going to start to flush off that chloride, that bromide, that fluoride. And so that's where you can see some of those Herxing reactions. And if you're thinking about starting iodine, I really encourage you to work with a provider on that, because it needs to be done carefully and with observation, but it can be very beneficial. Okay, myth number 6, if I start thyroid meds, I need to be on them forever. So this is a question I get a lot, and I have had several patients where this has not been the case. So if you have had your thyroid removed completely, or if you've had treatment to like radiation to basically kill your thyroid, yes, you will be reliant on those thyroid medications. You need to take them, otherwise you're not going to get thyroid hormone. So that is the exception here. All of those other situations where I personally have dealt with patients are going to be, for example, my Hashimoto's patients. So I've had patients who were miserable, super tired. They weren't able to live their everyday life. They were cold all the time. We had to start something for them to be able to function daily. After we started this, we continued to work on things like their gut health, detoxing, specific detox protocols based on what their toxin loads were. We also continue to work on nutrient replacement like selenium and zinc and iron and those types of things. And what I'll see is I have had patients where when we get the rest in check and that body's able to heal, we actually see their thyroid numbers start to go up. So their TSH goes down, their T4, their T3 jump up, because now they're getting too much thyroid hormone. And so I have had patients where they've been on thyroid hormone, we've healed, and now their levels are too high, and we have to bring them off of that thyroid medication because now they're getting too much. Their body's making more of it. The other thing that I have seen is when we have significant weight loss, sometimes we can come off of thyroid medication completely. Remember, metabolic health is a driver of thyroid health. And so if we're really metabolically unhealthy, we're overweight, we're obese, we're insulin resistant, it's going to increase more of that D2 in the brain, but it's going to reduce more of that D1 in the tissue. And so we're not making that conversion. But when we get healthier metabolically, we're going to start making more of that T3 conversion. And again, what we see, oh, now I kind of feel like maybe my heart's racing a little bit. Maybe my thyroid dose is too high. And we check those people, and yes, we either need to bring them down on their medication or we need to come off of it completely, because now metabolically they're in a better place and their body's creating and making more of that T3 on its own. So it is not true. Again, I personally have had many patients come off of thyroid hormone completely after we've been able to fix and clean up what the trigger is for them. I do like to use this in those patients who are miserable and not functioning and just need a quick win. Because if we give thyroid hormones, including T3 in that, and they feel better, like they're able to get up, they're able to live their daily life, they're not taking naps in their car anymore, we know that's a big thyroid problem. So we can help kind of use that as a bridge to get through, like I'm able to function now, which means I'm able to actually work more on my health toward doing some of these other things that are going to make me healthier with regard to my thyroid function. So it's a great way to see, hey, if I give this, do symptoms improve? Okay, it was a thyroid issue. We really got to dive into our thyroid management and everything else surrounding thyroid. The other really important conversation that I have with patients is surrounding medications and prescriptions. In my opinion, those two are very different. So I see a prescription as anything that can go to the pharmacy, right? And they give you. Now, that can include medications, which are things that are introduced to the body that should not be there. For example, lisinopril. Lisinopril is a blood pressure medicine. It is a medication that was created to change the way your body works to lower blood pressure. Or SSRIs. These are medications. They are not natural substances in your body that are created to change the way your neurotransmitters are working for mental health conditions. So that's a medication. When we look at prescriptions, you can have prescriptions that are natural replacements, and that's what we see with thyroid hormone. So we're not introducing something that your body doesn't naturally make. We're putting back in what there's not enough of, and we're replacing it We're not introducing a foreign substance. So my patients find that very helpful to understand the difference. You know, a lot of them come in like, well, I don't want to be on medications, right? They have kind of the stigma around being on a medication. But there's a big difference between a medication of something that shouldn't naturally be in your body and a prescription that is actually just helping give your body enough of what naturally is supposed to be there. So I think that can be helpful for people to understand the difference.
Absolutely.
Okay, so myth number 7, you have Hashimoto's, but we don't need any treatment right now because your levels are still normal. So let's talk about Hashimoto's really quick. I like to give the analogy of COVID, right? So Hashimoto's is when we've checked those TPO, those thyroid peroxidase antibodies, and those thyroglobulin antibodies, and they're high, which means you have antibodies being created by your immune system to your thyroid, okay? That's high antibodies. When we think about this in the COVID analogy, everyone understands we want antibodies to COVID because that means the immune system has identified that as bad. It's kind of tagged it as a bad thing, and your immune system is going to attack it. When we talk about this in regard to thyroid antibodies, your immune system has tagged that thyroid as bad, and so it's attacking it. That is not a good thing. We don't want that. So this isn't a thyroid problem. This is an immune system problem. This specifically, going back to my story, is what happened with me. No one ever checked my thyroid antibodies. It wasn't until I dove into this holistic world that I even knew that I had Hashimoto's because they only checked the TSH. So it's very important hormone that we make sure we get so we know the full picture of what's happening with your thyroid function because it does change our treatment recommendations moving forward. If we're able to catch those thyroid antibodies early, meaning they're still at a somewhat low level, I found it much easier to put those patients into remission when their antibodies are still low. So it is super important to check this, and it is important to treat it immediately, not just this, we'll just wait until it's bad enough and then we're going to treat you. The sooner we treat, the better. So we can stop that body's attack response, that immune system attack response, by doing things like detoxing, like gut work. You know, when I look at autoimmunity, and I treat a lot of patients with autoimmune conditions, and I believe there are 3 main pieces to this: genetics, toxicity levels, and then our gut. And if we can help in those 3 areas, a lot of times it's not unrealistic for us to put those autoimmune conditions into remission and for the tissue and the body to heal. If we don't treat antibodies, right? If we just say, hey, antibodies are what they are, doesn't mean anything, it just is what it is, and they continue to creep up, you can actually have such a severe attack response that it completely destroys the thyroid gland. And now you have no gland left, and therefore you have no thyroid production left. So I do not believe that it is something where we just kind of wait and see and watch until things are bad enough to treat. I think the earlier we can intervene, address some lifestyle pieces, start some medication if we need to, if it's warranted, I think the better off people are in the long term.
Yeah. And really at the foundation of treating Hashimoto's, like you had said, should be those lifestyle changes and trying to limit that immune response, that hyperactive immune response, as much as that person can control. All right, next myth: dietary changes are not necessary with Hashimoto's, with autoimmune thyroid disease. And this couldn't be farther from the truth because there are controllable things that people with Hashimoto's can easily look at. The biggest one is going to be gluten. So gluten, unfortunately, is found in almost everything, but the traditional sources are going to be things like wheat, rye, barley, oats, and then gluten can sneak into a lot of different products, especially processed foods. The reason that this is important is the protein within gluten is called gliadin, and gliadin is similar structurally to a lot of our thyroid proteins. So when we look at thyroid peroxidase, thyroglobulin, and transglutaminase, those are all thyroid proteins that are going to be relatively similar to gliadin, that protein within gluten. The importance of this is that molecular mimicry. that the immune system can get confused, or the immune system can have a hyperactive response to people who are regularly and chronically exposed to gluten, in that the immune system will then start going after those thyroid proteins. And that's what can lead to degradation of thyroid function and circulating hormone levels, and then even over time degradation of the gland itself, like Jackie was talking about. And again, all of this is because molecularly that structure of gliadin is similar to our actual thyroid proteins in terms of that chemical or molecular structure. So with that said, the biggest controllable is gluten. If we can cut out gluten for people who are predisposed to Hashimoto's or predisposed to high antibody production, by taking away that gluten, being on a strict no gluten diet, we can really push down that antibody production against the thyroid. And that's something we can track over time when we get serial lab tests to especially look at anti-TPO antibodies, anti-thyroglobulin antibodies. And as we see that production of those antibodies against the thyroid gland go down, we tend to see symptoms improve, overall full body inflammation improve, and we know we're doing everything we can to preserve that thyroid gland long term. And finally, we're almost there. Here's the last myth. Hashimoto's cannot be treated. And we went over that a little bit with diet and cutting out gluten in the last section, but there's a lot of different approaches to this beyond just watching, waiting, and giving thyroid medication. Detoxing is a huge part of this. When we look at how the immune system functions, the presence of things like heavy metals, environmental toxins, toxins from cosmetics, all of those can play a role in that hyperactive immune response. And so counseling people on how can we clean up these different areas to optimize thyroid function is huge. And it's just one of the pieces to the puzzle. Overall gut health is also a big part of this, because the vast majority of our immune system, over 80% of our immune system, is in our GI tract. And so if we address not only the immune function there, but also things like leaky gut, where there may be some underlying inflammation, where there's too much getting through that gut wall lining, that can play a huge role on conditions like Hashimoto's. This is one of the reasons why there's such a crossover between celiac disease and Hashimoto's, both of those autoimmune processes. And then, like Jackie said, one of the funnest things for us as providers is having people come in hypothyroid, not feeling well, very high antibody levels, and working through these pieces of lifestyle and seeing those antibodies come down over time and putting Hashimoto's into remission, which can happen as long as people are willing to put the work in. All right, that's all we have today. Thank you for sticking with us. If you know of somebody, your family, friend, who is dealing with long-term thyroid issues, pass this episode along to them. Hopefully they can take one or two pearls out of here that they can use and implement in their life to improve quality of life, improve that overall thyroid function. The next episode is going to be a pretty fun one. We're going to talk about food. We're going to talk about the food pyramid, breakfast, what American eating looks like, and I think you'll have a lot of fun with that next episode.
Thanks for joining us today. The information on this podcast is for educational purposes only and is not intended to replace medical advice or to be a substitute for professional medical diagnosis or treatment.